Welcome to the Centennial Care Training at Parents Reaching Out. This is Lisa Rosignol, and I'm the Healthcare Liaison and the Echo Clinic Coordinator. On the phone, would you guys like to *6, unmute yourself and introduce yourself, starting with Yvonne? Oh. Yvonne?
Did I unmute myself?
Yep, you're good.
Okay, thank you. This is Yvonne Medina. I'm the Physical Health Care Coordinator Supervisor with Presbyterian Health Plan here in the North Region.
Awesome. Thanks for joining us. And then start.
You're welcome.
I unmuted it. Okay. And then the other person I forgot already. Is it Erica? Yeah. Wendy? Oh, go ahead. Erica?
Yes, this is, oh, sorry. This is Erica Archuleta from New Mexico Medical Assistance Division, the Physical Health Unit Manager.
Great. Thanks for joining us.
Thanks.
And then *6. Perfect. Okay. And then Wendy?
Yes, this is Wendy Padilla with Blue Cross Blue Shield of New Mexico in Medicaid Operations. Thank you.
Thanks for joining us. And then *6 to mute. And then we'll go ahead and go, I'm going to have to mute her, I think. And then we'll go ahead and go around the room and introduce ourselves. Let's see if we find a lucky person. And then there we go. Naomi, you're on. Here we go.
Good morning. Naomi Sandblaze from Parents Reaching Out.
Okay. There you go.
I'm not awake yet. Oh, I don't think
Okay, hi. Oh, you're lucky. It's not coming. It's broken. There we go. Okay.
I'm Andrea Leon from Parents Reaching Out.
Awesome. And that's as far as it goes. So the rest of you are lucky. So behind the camera. Go ahead.
Jessica's back with Parents. Gala Yasevich, Parents Reaching Out. Laura Carden, Parents Reaching Out.
Right, and then now we can get the two of you guys. There you go.
Melissa Reed Safari with Parents Reaching Out. Misty Aracion with Parents Reaching Out.
All right. Well, thank you all for joining us today. We're talking about the exciting world of Centennial Care. It makes me super nervous to have the Medicaid department on the phone, but at least we know we're getting accurate information, so that's good. So let's go ahead and get started. We're going to talk today about Centennial Care and EPSDT. In the business, people will either say EPSDT or EPSTAT. I prefer EPSTAT, but when I've been to like national conferences, people like to say EPSDT. I don't know. I like EPSTAT. Okay, next slide. And our executive director is now an IT whiz, so she's doing her best over here. Okay, so the agenda for today, we're going to talk about the Patient Protection and Affordable Care Act, what we call ACA Obamacare, or what the biz speak is PPACA, which is awkward. And we're going to talk about what that means to healthcare now. We're going to talk about Centennial Care, and we're going to talk about EPSTAT, and what it means, what the acronym stands for, and what it covers. Okay, next slide. So the Patient Protection and Affordable Care Act, also known as ACA or Obamacare. The Affordable Care Act is designed to expand access to insurance, increase individuals' protections, improve prevention and wellness, and improve quality and the healthcare systems. So prior to the Affordable Care Act, what a lot of people don't understand about healthcare is that it's driven by the state. So there are federal mandates that are put out, but each state really has quite a bit of flexibility in what they can cover. And the New Mexico legislature has been one of the leaders actually in covering things like preventative care. When I was in college, I worked for Blue Cross Blue Shield of New Mexico, and I worked both on the Texas side and on the New Mexico side for the providers. And it was really interesting to me that to see how different the plans were. Where in Texas, the same plans, the deductibles were like $5,000 starting at, and they didn't cover women's wellness visits And on the New Mexico side, the deductible started at like $1,000, and it did cover women's wellness, and that's all driven by the legislature. So that's important to understand. The Affordable Care Act also articulates really clear standards on the fact that we want to make sure that we're providing good care, not just expensive care. And so it puts a lot of restrictions and kind of recommendations in what does good care look like, and it defines that. And it's looking for overall improvement of systems across systems and for them to work together. Within the Affordable Care Act, what a lot of people don't know is that it puts forth $500 million in research per year. And they gave that to this nonprofit called the Patient-Centered Outcomes Research Institute. And it's their job, using groups of consumers, to prioritize research dollars around topics that will benefit patients specifically. So there's quite a bit in, it's a really large piece of legislation. If you sit down and you try to read it, it's about 650 pages long. Really, really boring. Gala just rolled her eyes. So she's behind the camera, so you couldn't see that. But and it really is like, what I tend to do when I need something out of it is I just do a term search, because it's just really, really big, and there's sorts of odd stuff in there. But it's a pretty large piece of legislation. So go ahead and go to the next slide, please. So what changes has ACA made? So the children now can be covered on parents' policy up to the age of 26. The only place that I've seen this be an issue is if somebody wants to get married before the age of 26, which doesn't happen a huge amount, but it happens enough. This will exclude them from being able to stay on their insurance till age 26. But a lot of people are staying in college a lot longer and staying at home longer. So it really does work that way. Preventative services are included without paying a copay. And so for New Mexico, that wasn't a huge deal because a lot of our plans already had that, just for, well child and wellness visits. But now every state is required to have that. And that there's a restricted annual limit and no lifetime limits. So my kiddo used up her lifetime max in her first 10 months. And I remember when I worked in insurance saying $1 million, how would that ever happen? And all you need is one pretty major illness, and it can happen pretty quickly. Or even, some chronic illnesses. Diabetes medication is incredibly expensive. Hepatitis C medication and treatment is incredibly expensive. So just depending on MS drugs are incredibly expensive. So a person that has an illness can do that pretty quickly. And so this says that you can't do that anymore. A person's condition costs what it costs. Okay, next slide, please. So we're now in our third year of the ACA. And so the changes that started in January 1st right away was affordable coverage options. And we're going to talk specifically about the ways to buy insurance, because there's a lot of different options now. Eligible people, government programs, and help paying for coverage. So we're going to talk about the tax credit and eligibility expansion. Pre-existing conditions covered. This was huge, and this started the second that the legislation went into place. There was a time where I was uninsurable, so I had to work at companies that offered insurance, and if I left, I had to pay these things called COBRA rates, which was whatever the company was paying plus my premium. So I was looking at about $1,400 a month just to keep a minimum plan, a PPO or an HMO. Not very good coverage, but it was the only way I could keep insurance. And that went away instantly. And that's huge for children with special health care needs, because even if your child is medically stable, if they've ever had a major condition, the insurance companies previously would have you, and the applications even look very different, because they would have you fill out every surgery, every type of thing, and they can't do that. Mm-hmm. And essential health benefits, EHBs for all. And this is really exciting because some of these EHBs include things like habilitation. So prior to the Affordable Care Act, you could do rehabilitation, which is where somebody had an injury or an illness, and rehabilitation would get them back to baseline. Habilitation is saying, we're going to let you get better. You don't have to just get back to baseline. If you're a person with emphysema and your baseline is being able to just walk around the block barely, we're going to provide you with health care, medically agreeable and approved by our medical director. We'll allow you to go into some type of program or treatment that will allow you to start running in marathons. If that's really what you want to invest your time and your energy in, and your co-pays, and we'll do Next slide, please. So health plans will cover certain medical services, and again, in New Mexico, a lot of these were already covered. So this is not huge news. Maternity care is huge, though. It used to be up, and I think we forget about this. I forget about this. You used to have to buy a maternity rider. Maternity was often excluded from plans, even in employment, and so you had to buy a rider, or you would have to go and get into a sort of, you'd sign a contract with your OBGYN about, I'm going to pay $300 at the beginning and it'll cover this many of my visits. And that's really different. The birth control in the Affordable Care Act is the thing that has been tied up in the Supreme Court, because if all these plans that we're talking about have to cover birth control, then the employers really fought back, because there were large employers that were Catholic or Christian and didn't believe that they should be covering birth control, and so that's something that's been in the Supreme Court since this started, and they haven't made a full decision yet, I believe. Or actually, I feel like they might have. Cindy, do you know? You follow the news pretty well. Do you know if they wound up, or anybody on the phone? Danita, do you know if the Supreme Court wound up making a decision on the employers and the birth control?
I actually do not. Since I left the Family Health Bureau, I kind of lost touch with that piece of legislation. But I would certainly be happy to contact Janice if she's not on the line.
Yeah.
Since she's Bureau Chief of Family Health Bureau now.
Oh, okay. I could just ask her, but that'd be great. That's a good idea, because it'd be interesting just to know.
Yeah, definitely.
I think that they ruled that it does have to be covered. I think, but it's in the Supreme Court, so I think that they're just kind of, I think when something makes it to the Supreme Court, they let them kind of do what they want in the meantime. But I'm not entirely sure. So I can send out an email and follow up with you guys on that with Janice. So, but I know.
Lisa, I'm about 99.9% sure that that's correct.
Yeah. Okay. Cool. And I'll ask her. And Danita, do you want to introduce yourself for everybody that's already here?
Sure. I apologize for that. My name's Danita Richards. Well, I'm married Danita Richards Wolf, and I am working at United Healthcare. My main function is working with the community health workers and trying to expand that program in the state.
Great. Thanks for joining us.
Yeah, I'm glad I could.
Yeah, and maybe afterwards you can stay on the line and talk.
Oh, sure. You bet.
Okay. All right, and then we're going to go ahead and mute you on our side. There we go. Just got to mute Danita. All right. So we'll follow up on that and we'll find out, but we're pretty sure on that one. Okay, any questions on these parts so far? And gender, what's really important was that gender cannot be used to determine insurance rates. I don't know if you guys remember, but you used to have to sign if you were a male or a female. And when men were younger, they're more expensive because they're less responsible, I guess. They're more likely to be injured or do dumb things, I guess. I don't know. Sorry, but risky behavior. I'm sorry. That's a nicer way to say it. But that we have this Shelton. Shelton, do you want to introduce yourself? You came on and your mic is open.
Hello, my name's Henry Shelton. I am a care coordinator for Presbyterian Centennial Care.
Great.
And I have about a half dozen EPSDT members on my caseload that I'm working with regularly. I'm also a ex-school social worker that worked in special ed with a lot of these types of students, these types of children with these types of disabilities and challenges.
Awesome. Well, welcome. Thanks for joining again. We've had actually kind of...
You're very welcome.
Yeah, thanks. And we've had quite a few people join, and we'll just go ahead and do a quick little roll call again, just to introduce everybody else that's on the call. We have Gonzalez. Is that Janice Gonzalez? But she's not here. I'm going to mute her. Janice? No. Okay. How about Elcon? That's Janelle, right? Janelle Elcon? Elcon? You want to say hi? Oh, how about Sandy Potter? Would you like to say hello?
Sure. This is Sandy Potter. I'm the Divisional Vice President for Medicaid Clinical Operations for Blue Cross Blue Shield of New Mexico.
Great. Thank you so much for joining.
Sure.
Go ahead and meet everybody. Okay, so we're just getting into this. We were just talking about how women and men, okay, and so it looks like Jan is saying she's having trouble with her audio. So if you want to just type questions or comments into the chat, that'd be great. And so, yeah. And then it looks like we came off of shared screen. There we go. There we go. Okay, so the ways that you can get on now to insurance, there's job-based coverage, which was the same as before, but now employers are kind of specifically given these mandates of they have to have the care, they have to have the birth control, which we talked about, which is the one that's kind of controversial. There's also the health insurance exchange, and that's been interesting because it started as having the 4 providers that we call BUMP, Blue Cross, United, Molina, and Presbyterian. Blue Cross left the exchange, I believe, at the beginning of the year, and Presbyterian is preparing to leave the exchange also. But this allows people, small businesses, I believe, that are under 12 employees. This allows individuals that are self-employed or stay-at-home families that want to get insurance that way. And depending on what their income is, then they can get a tax credit. And so it gives them a break on their premiums because it estimates how it'll come out in the taxes. And it's important to be accurate on that number because when you file your taxes, if it's inaccurate, then you can get charged at the end of the year. So. And then the last way is Medicaid. And since our state was one of the ones that took the expansion, then we have a lot more people that get it through Medicaid. So the first thing we do when here at Parents Reaching Out, when we meet people, and I think that's probably the case for a lot of the people on the phone, is we ask them to just apply for Medicaid. Even if they are not sure, just apply, because that denial is going to give you access to some other services also. And so we want you to just go ahead and apply. And people, I mean, it's taken us 3 years to really convince people that the expansion is such that people that didn't qualify before can, including, you know, healthy single adults age 19 to 64 that previously didn't get insurance. That also, it doesn't make you a bad American to have Medicaid. That's a really big prospect that we have to address constantly. Families feel guilty applying for Medicaid and taking advantage of the system. And we really have to kind of buffer that and teach people that there's a different way to engage with healthcare, that it's a civil right, and that it's important to the lifespan to have quality healthcare. And it's also important that we have healthy people in these systems because the cost of them being low, they wind up offsetting the cost of supporting people who have chronic or expensive conditions within the system. So it's important that everybody participates in these systems in order to make it financially sustainable. The healthy people in these systems are important. Good, next slide, please. So let's move on to Centennial Care in specific. So Centennial Care is the name of New Mexico's Medicaid program. It was called Salud previously, and partially the name change came with converting to something called an 1115 waiver. And some states opted to take this, and we are one of those, and it came with a renaming. It also came, and this is where it gets kind of confusing, that it absorbed several 1915 Medicaid Part C waivers into the 1115 Medicaid waiver. So sometimes when we're talking to people that have kiddos that qualify for like the DD waiver, the developmental disabilities waiver, it can get pretty confusing for them. But it's important to understand that we have that. It's a program that provides health care coverage for people with low income, disabilities, and other that cannot afford traditional health care. So again, we talked about, and on Friday, those of you that are on the call, we can actually prepare to Zoom. We're having Orlando Vasquez from HSD is coming in to talk to us about I think 20 of the categories of Medicaid eligibility, just to kind of understand when they're talking about a 420 category of eligibility and how some people can actually be eligible for like 4 different categories, and how they decide which one to put them into, which is kind of going pretty far down the health insurance rabbit hole. But it's important when we're working with families and they come in with a letter that says, I haven't sent that invite out yet. I have not sent that invite out, but I will do it tomorrow, and hopefully not re-invite you guys 50 times like has been happening this week. So every state has a Medicaid program that is overseen by the federal government, and states receive a federal match. And so this is part of why Virginia didn't take the expansion, because in the ACA and then in Medicaid expansion, we get different percentages. So in a couple of years, we're actually going to be responsible for taking on more and more. We'll get there, guys. Just hang in there. We're actually going to take on more and more of the cost. And so I believe by 2017, each state is supposed to take on 90% of the cost. However, in states that are very poor, we still get our federal match. So we get a 79% federal match. So we're still paying, I'm so bad at math, like 21 cents for every dollar that the feds are giving us. So it behooves us to take the expansion. But other states like Virginia does not get a federal match because the majority of their state is pretty wealthy. And so they get, it's going to cost their state a lot of money as the expansion goes on and they take on more. Okay, so who is eligible? Oh, I don't know where you are. You're way past. There we go. Okay. And states are required to offer certain services to Medicaid recipients. This is one of the ways that the protection and advocacy groups like Disability Rights New Mexico are able to kind of keep groups and keep the state Medicaid in line, is that if they are violating some of these federal mandates, then they can sue the state on those federal mandates and stop or encourage these things to happen. And so one of the ways we've seen in other states where they took the expansion but they weren't offering all of the services, then they sued the state, and then the feds wound up not paying the state their reimbursement rate because they weren't offering the correct services. So it wound up costing the state quite a bit in fines. The state shall remain nameless at this point in case we're friends with the state. So, next slide, please. So to apply for Medicaid, there are a couple of different ways. You can apply by filling out an application at the local income support division office. And that is going to be probably the easiest for most people in rural and tribal areas because they might not have the internet access. But they're challenging. The offices are challenging. Anybody that thinks that going in there and doing this, being on Medicaid and accessing all these services, I don't know, have ever actually had to try it because they're often challenging. They're often full of lots of people who are hungry and scared and screaming babies because they don't have childcare and maybe they had to walk several miles to get there. So there was a program at the University of New Mexico where they used to make resident medical students, they would take away their cell phone and they would make them navigate using public transportation to the Income Support Division and apply for Medicaid. They don't do that anymore because their curriculum doesn't really allow them that much time, but it was really interesting for them to see how a lot of New Mexicans have to get to their systems. The easiest way is yes.state.nm.us. And when somebody is a monolingual Spanish speaker, I like them to be able to go there because the site also converts to Spanish, and so it's also very friendly in that way. When we have somebody who is illiterate, though, they will require some support, and so perhaps that's something that the care coordinators could assist with. I think they probably all have tablets that could go online and help apply for that. Well, actually, once they have a care coordinator, they already have it, so never mind. But maybe you could be enrolling the whole family when you guys are out there and making sure. There's a big national push to try and get the families to be applying. They're applying for their kids in some ways, but outcomes are turning out better if the entire family has Medicaid. So they're working really hard to do that. Next slide, please. There are also these enrollment fairs, and at our family leadership conference, we've had groups that come to enroll individuals. So we're doing that big push, and then now we're working really hard to help the legislature fund it appropriately for all the people that came on. So what you're going to need to apply is proof of identity. Birth certificates are great for little ones. Proof of residency, you do need to be a resident of the state of New Mexico. So the proof of identity can be driver's license for children over 5 can use a shot record or school ID. Children under 5 it would be a birth certificate. You need a proof of citizenship. So Medicaid eligibility requires citizenship. So passport, birth certificate. Resident aliens must provide a resident alien card and must have lived in the U.S. as a legal resident. This gets really tricky for me when we get to the DACA and the DAPA folks. So at that point, if there's a question on that, I tend to refer to the New Mexico Center on Law and Poverty because at this point, they're stronger in immigrant healthcare than I am. And so I just double check with them. And they have a really great training, and they provided us with a chart. But I don't always understand what they're talking about. So I tend to either have them call over, or I call over, or we call over together. It just depends on what the situation looks like. Social, yeah.
Can you define or spell out those 2 acronyms you just used?
I have no idea what they are. So that's something that we'll have to do. DAPA and DACA are like a certain class of immigration. And I don't remember what it is. We had it on a form. And so typically they know if they're DAPA or DACA, and they'll tell you. But that's why, I mean, and I've done trainings on it, but I cannot remember what it stands for. And so I really encourage the New Mexico Center on Law and Poverty will go out and do trainings pretty frequently. So if that's something that your groups are interested in, I would really encourage to reach out to them. And again, that's why, and I just don't want to mess with people's livelihood. So I just, ask them to go straight to the source in that. And they have a very robust healthcare area that's doing a really great job. And so I do want to encourage people to utilize them for that. And so proof of income, so any income into the household in the past 4 weeks. So 1 month's worth of check stubs, most recent, and if one is missing and if you don't have any, you can get a letter from your employer stating the gross amount for that missing check if you have a missing check, or if you're employed otherwise. This is something that New Mexico Center on Law and Poverty talks to us frequently about, is that income support cannot deny you coverage, though, based on not having income. And what they say is this is particular for the immigrant population where the child is Medicaid eligible and is a citizen, but the families might be migrant farm workers or undocumented. And the employer is paying under the table, so they don't want to write a letter because they're that would open them up for tax fraud or something of the sort. What the center, the New Mexico Center on Law and Poverty asks families to do in that case is you can submit a letter that says, I, Lisa Rosignol, with the understanding that I could be prosecuted in federal court, and telling you that I make $2,000 gross per month, and that they have to accept that as income reporting. And so families sometimes won't even reply because they're afraid for retaliation, but they're really not supposed to be doing that. And if they do, then the New Mexico Center of Law and Poverty would really like to know, because then they can go after them for that. So you do need to have income. And it really comes down to the taxes oftentimes. So when it gets into custody, we've had that conversation before, whoever files the child, if it's in a split household and their children are split between, and a lot of times in divorce and custody cases, they will articulate in the document who gets to claim the child on their taxes. They would then be the Medicaid, the account that it would all work off of. So they would receive the food stamps, they would receive the Medicaid. And then proof of residency, so a utility bill, a letter from your housing, a gas or electric bill with name and address on it. If your bills are included in the rent, a copy of the rental agreement or a copy of the mortgage, a letter stating living arrangements. So if you're living with a parent, grandparent, a letter stating that arrangement. And then proof of insurance, if you have other health insurance, it's okay. You can have Medicaid and other insurance. Medicaid as secondary is actually really helpful for people that have pretty big illnesses, because Medicaid as secondary picks up whatever's left. So it'll pick up copays and deductibles. So people, even if they have an employer plan, if they have chronic illnesses, then Medicaid as secondary would be really helpful. Another benefit of having Medicaid as secondary is if somebody has like a preferred provider plan, a preferred provider option, a PPO with a deductible, and they have a provide network and a preferred provider network and a non-preferred provider network. If the person winds up having to go out of network to get care, then they're responsible for sometimes up to 80% of the cost. But Medicaid does not have to have preferred when you go when it's secondary. I think there was somebody in chat. Did we get everybody? Okay. Okay. So, and then proof of pregnancy, and that was more important. I mean, they still want to see that because there are certain pregnancy riders, but that was more important when you had a work insurance, or if you had a private plan before, you could go get just pregnancy and family planning coverage, and that had a huge income gap, just again because it was so expensive, and they wanted to make sure that people were going to the doctor and getting the appropriate prenatal care. Next slide. And this is a repeat slide, so I need to remove that. Okay, so Medicaid, and I think these, and you guys on the phone can correct me, these are slightly old numbers, so they might have changed, but I think they're pretty accurate. But Medicaid with no copayment, the straight Medicaid household income must be under 185% of the federal income guidelines. So you'll see that there are different groups. So 0 to 6 years of age, 240% over the federal, that's how much the family can make. And then it's adjusted for how many members are in the household. And the members in the household, often they count as the people that are being filed on the one tax return. Because I've seen cases where we worked with Medicaid eligibility where there were 6 people in the household, but only 3 of them were on the taxes. And it wound up working out better for the family than having all 6, because 2 of the people were adults and they were earning income, but they were filing their taxes independently. So they were able to just work with the 2 children and the grown-up income. And then something changes at 6 to 19, and it goes to 190%. We also have the CHIP, which is the Children's Health Insurance Program, which is state-driven, and this does have small co-pays. It looks like it's usually about $5 for general office visits. It's not huge. And the prescriptions typically don't have a copay. And again, there's that age breakout of 0 to 6 years is 300%, 6 to 19 is 240. And children, again, are eligible even if they have health insurance or have voluntarily dropped other insurance. If you decide to just do, so for example, here at Presbyterian, we have Presbyterian, but here at Pro, my kiddos that were Medicaid eligible, I just kept them on Medicaid and bought my husband and I the plan. And then when our income changed, one kid fell off of the CHIP program, but the other one's on a waiver. And so we just had to bring her into the Medicaid, or into the plan here. Next slide, please. So the different programs, again, we talked about this. So all of the programs are run by the managed care organizations. The BUMP, Blue Cross, United, Molina, and Presbyterian are the groups. We really don't talk about which ones are better. We just do let families know that Presbyterian is not working with UNMH for the most part, and now United is not working with them. I know that United is, because that's who we have, if a child is established with a provider and there is not an adequate replacement within the Presbyterian or New Mexico system, they are allowing with prior approval at this point for them to see other people, but they are not interested in participating with UNMH at this point. There's fee for service, and so the families that are Native American can choose fee for service, but it's important to work with them and talk to them about the fact that they cannot get long-term services without choosing an MCO. So when we talk about long-term services for children with special health care needs, adults, anybody that needs kind of anything extra and community-based, they are going to have to select a managed care organization. And it's something that we talked about in one of our echo clinics before that Wendy did. Sometimes the families drag their feet, and it can really it really is important for us to work with them and leverage their fear and their concern, because delaying that process delays their access to community benefits, because all of this takes a certain amount of time. And so we had a family that was really concerned about moving into an MCO. They took a really long time. They wound up getting discharged right when they chose their MCO, and so they didn't have the community supports in place that they could have if they had started the process when they were inpatient. But, you know, we talk with Dolores often. The reason that Native American families are concerned about the MCOs is in the past, the MCOs were not great about paying outside providers. And so people would be sent to UNMH, they would be sent somewhere, and then they would get a $30,000 bill, and there would be no recourse for them. But the MCOs have worked very hard to streamline and fix those holes, and we've heard good reports that that they are paying appropriately, that they won't even make the appointment with the provider until all the prior approvals are in place. But I still have to acknowledge historically that I understand why they're skeptical. And but if they want those long-term services, and if you call the Human Services Division, if you call Teresa Ballinger is the Native American liaison, she can walk individuals through that, and they have spreadsheets that can kind of show you what the value-added benefits of each MCO is, because some of them have different, they all cover traditional healing, so medicine man, curandera, things like that, but they're at different rates. Some provide like non-medical transportation to the pharmacy, so that's a big value-added benefit. They all have to cover transportation to and from doctor's appointments, that's important. And they're going to come with care coordination. So if somebody has a chronic illness, that's going to be very helpful. The majority of families who do qualify, though, receive services from a managed care organization. And so that's why we're really glad to have the MCOs on the phone with us today. I think we have everybody today. Next slide. So this is a really wordy one, so I'll try not to just read it, but care coordination is a big piece of the Affordable Care Act, and it's something that nationally we're working a lot on. They said it over and over again in the ACA. I think it's like 32 times when you search the document, if you search the legislation, but there's not really a definition of what that looks like. And so on a national level, and what we're seeing is we're seeing something evolving. New Mexico has really taken the lead. I think we have about 3,000 care coordinators. This gets kind of confusing with case managers, and there's this new term called care managers that's emerging that's kind of a combination or a confusion. But care coordinators are specifically responsible for helping to kind of move the healthcare lines along. They're very, very important to have a good relationship with. And this is something that, when I've been misheard, has been controversial of what I say, but I really encourage families that if they're not getting good response from their care coordinator, if they're not feeling comfortable, to fire them. And not in a mean way, but to get a new care coordinator, because they're so important. They're just so important, and families need to know that they have the right to get a different service. And, you know, I am staying with my insurance for my kiddo just because of our care coordinator, because she is just a beast. She does a really great job for us. She knows our family, and she, you know, does things on time, moves quickly on things that are important, and has a sense for our family of what stuff can wait. And so I know there are really, really quality care coordinators, and there are some care coordinators that are going to be better for some families than others. So it's important for families to understand that. And on the other side of that, then we're working really aggressively with the care coordinators to help them understand other resources so that they don't have to do all of this stuff, because that's not necessarily what they're supposed to be doing. All Centennial members will receive a health risk assessment. And this was really difficult at the beginning because people weren't entirely sure what the insurance companies were calling for. I believe that it came because there was this period of time where all the insurance companies were doing quality surveys, and they were calling everybody and doing all these quality surveys. But a lot of people didn't really understand. So the first thing that we ask families to do is to try to complete their health risk assessment. And if they don't know if they've had one, or if they know they haven't, we just ask them to call member services and complete it. Depending on what their score is, they will be put either on, if they're like a 1, then they get contacted once a year. They just check in to see if anything's changed, just to determine, because there was this realization that families don't necessarily even know how to use their health insurance. Even the old salute, but especially with the expanded care of Centennial care. Families were so used to being told that's not covered, that they kind of just don't even ask. And so that was the first step. If they get, I believe, a 2 or a 3, then they get moved into something called a comprehensive needs assessment. And this is where a care coordinator comes out to do a comprehensive needs assessment. And they're typically going to be like a nurse. They're going to be somebody with a good amount of experience in healthcare and a good amount of education. And they're going to come out to the home and they're going to do a comprehensive needs assessment. Now, we do some coaching with families around this because families are not deficit-based and healthcare is. So what winds up happening is the care coordinator or the comprehensive needs assessment they come out to do the comprehensive needs assessment, and families are in the, oh, our little Timmy is just so precious and a shining gem and does so much, look at all these great things. And that's awesome, but this is a deficit-based system. And so then the care coordinator leaves and they get a report that says you don't qualify for anything because little Timmy is so well off. And the families can't understand what happened. And so what we really ask is that when they're working, doing their comprehensive needs assessment, that they talk about what does little Timmy's worst day look like? What does it look like when the kids are trying to kill each other in the living room and you're burning the spaghetti and your husband or your partner, is working late? What does that look like and what's the level of care there? And if you're uncomfortable, you can ask the child to not be in the room during that part because, you don't really want them to get bogged down by their deficits. But this is a deficit-based system, and so that's important. We don't want people to be dishonest, but we want them to be really clear on what the purpose of that meeting is. And so depending on what their score is, they'll get either a 2 or a 3. And the 2 or the 3 have different kind of budgets for community supports and can access different types of services. When they get a 2 or 3, then they can start to get access to a small amount of respite. They can get access to a significant amount of personal care services. So the people with the most need, like 3, can get up to 16 hours of personal care services. And it's important to understand the difference between personal care services for children under the age of 18 and respite. Respite is designed to relieve the caregiver. And so it's typically like date night. You can use respite to go to work. And it's kind of like skilled childcare because children with special health care needs often cannot just go to a traditional childcare setting. Personal care services are designed to enhance the life of the person with the illness or the disability. And so they're really not intended for you to go to work with. Some providers, that's between the family and the providers, they work it out, but it's really not intended for the parent or caregiver to not be there. So oftentimes how families will use a personal care service is that they'll work alongside the parent. So they'll help the kid with special needs bathe or do their homework while the parent or the caregiver had some time to play with the typical child or cook dinner or something like that. But it can be up to 16 hours. In Albuquerque, it's agency-based, so it's through Heritage Home Healthcare. So you can either send a person for 3 hours to have a non-paid training, 3 days, not 3 hours, non-paid, and then they become an employee of Heritage. Heritage is responsible for paying them. Or you can use one of their providers or a few of their providers, depending on their schedule. And in each city, it's going to be different on who they're contracted with.
Lisa?
Yes?
The 16 hours, that's for what period?
Week.
Okay.
Mm-hmm. Mm-hmm. I think it's less for a 2. I'm not sure what the max is, but I know we're a level 3 and we get 16 hours per week. Mm-hmm. So you can do a lot of leveraging of your day that way, but again, it's not intended for you to go to work. So it's challenging in that sense. Right now, my understanding is that the long-term respite is 100 hours per year. So that's not a lot. And part of the issue that they're talking about at the national level is that the Medicaid hasn't really figured out a way to pay for respite. So it's just a value-added option. That the insurance company can't bill Medicaid for respite because they don't have really a way to bill it. And so it's just something that they give to families because they understand that it's important, and they give as much as they think they can. They're working right now at the state level in New Mexico to increase that to about 720 hours for specific diagnoses, especially behavioral diagnoses, because children with ADHD, autism, because of the impact on caregivers and the studies that keep coming out, they are working to do that, but it hasn't quite been finalized yet. So we've been talking about community benefits. So adult day health, that would be in that community benefit. So you would need to get a 2 or 3 on the comprehensive needs assessment. Respite care, personal care, and it's intended to, and so people at those 2 or 3s, they're going to be looking for something called NIFLAC, which is that nursing facility level of care. That if they didn't supply you with this personal care and this respite and support the person, that they would have to live in a nursing facility or an institution, because they wouldn't be able to survive or be safe otherwise. So that's what they're looking for. And the community benefit has 2 options. You can have agency-based, which would be through, like, I think Consumer Direct is one of them. There's a couple of different agency-based, or there's self-directed, which looks like MEVIA, but it has a different menu of benefits. So the MEVIA waiver for medically fragile, and the developmental disabilities waiver. They're similar, but what we found when the waivers got rolled in is they don't have the community direct support that the self-directed waiver has for the DD waiver or the medically fragile waiver. So families can no longer pay themselves. Caregivers can no longer pay themselves at all for staying home and caring for their child. A benefit of the self-directed, it looks very similar because you still work with Xerox, you still have to do your own hiring of your respite folks, and you don't do your personal care. But let's say with your 100 hours of respite, you wanted to pay your mother, the child's grandmother, or somebody that you liked, you could do that through the self-directed, where they would go do fingerprinting at Xerox, they do a background check, they pay for all of that, and then you're responsible for doing the time carding and scheduling of that person.
So there was a clarification online.
Okay, great.
That the PCS hours are based on need, which could get as high as 40 hours a week.
That's great to know. Okay, great. So, so for, I don't know if anybody heard that or read that, but PCS hours can go as high as 40. So if a person needs more care. And I think the 16 is for under 18 in the sense that when they're in school, they're going to not be even expected to be home all that time. So some of the required benefits we've talked about. Most Medicaid beneficiaries are entitled to coverage of any of these services. So hospital care, obviously inpatient, outpatient. Family planning is included, and again, that's the controversial part. Immunizations are covered. If people are not Medicaid eligible, a lot of times immunizations can be done at the public health offices. They'll have immunization fairs. Hospitalization. Transportation is this sort of new kind of business and turn of events where, and especially in New Mexico, where families are having to travel from Silver City to Albuquerque to get specialized care. Children's Medical Services, Carrie Tingley Hospital, they do take clinics to those areas, but it's typically like quarterly. And so if people need intermediate care, then they're going to have to transport. But it's really important to guide families to work closely with their care coordinator, because if families just go on the trip and try to get reimbursed, it's not going to happen because they have a whole transportation division. They also have companies that they contract with that will drive them. And I've seen that there's even specific Native American companies so that they have contracts with Native Americans that can drive them back and forth from appointments. So that's great. And then it gives you EPSDT or EPSDT. Now, it's important when we're talking about, because this gets confusing to people, EPSDT is only for Medicaid, right? So you will not get this on the exchange. You will not get access to EPSDT on your work insurance. So some of this stuff will show why we kind of want kids on Medicaid because of everything that it covers. Next slide, please. Yes.
Insurance, private insurance, and your child or whatever covered under Medicaid and whatever, you know, like I'm just thinking of services like race, Medicaid or cosmetic. And so then you have Medicaid, straight Medicaid, and then work insurance. That way they can do that.
Yep. Yeah. So the question was, again, can you have more than one type of insurance if you have the Medicaid? And you can. You could have 4 different types of insurance. You could have a work insurance, and then you could buy a cosmetic dentistry plan, and Aflac. I mean, you can really have that. What order they pay is going to be the difference. So if you have a work one, that's going to be your primary, and then Medicaid will be secondary. So then they'll pick up whatever's left over. If something isn't covered by Medicaid, then your first one would cover it, and then you would have to pay the copay on that. Oh, now I got the clarifying PCS hours can go up to 40. So awesome. Okay. EPSDT is based on 2 principles: assuring that healthcare services are available and accessible, and assisting eligible children and youth to the health services needed. So this is often driven by legislature, and so and it's important to teach people about how to work with the legislature, because then they can, some of these things weren't included and weren't covered, but then families said, hey, this needs to be covered. So federal law requires that each state's EPSDT program provide a variety of healthcare services and preventative checkups to ensure that children are receiving the treatment they need and to maintain or improve their health. Next slide, please. So it stands for Next slide, please. Early periodic screening, diagnosis, and treatment. So the assessments must include checkups in 4 areas: physical health, vision, and hearing. The purpose of these screenings are to find any problems and/or conditions as early as possible so that they can be treated, and to ensure that children receive necessary health care on a routine basis. Shots, ongoing monitoring of existing conditions. So the 3 types of screening are initial screening, periodic screening, and interperiodic screening. So the initial screening is checkups that must be provided when a child enters the Medicaid program. And I don't know if you guys have seen the teen to tot letters if you have kids that are on Medicaid, but they'll send those out. It's also how I know that my daughter's primary didn't report that she had her well child check, because we still got one that said you still haven't had your well child check, which we have. And so we caught a clerical error from the office that way. Periodic screening, also known as the well child checkup, so that's the one the teen to tot, occur at regular intervals. And then interperiodic is a checkup or assessment that can happen at any time outside of regular scheduled visits. So, so you may have already had your 3-month check, but you realize because you've worked with our early intervention program that your kiddo is not looking at themselves in the mirror or babbling like other kids quite at the age. And so you can make an appointment to go in and talk about those, and it would be covered. Next slide, please. So any illness or condition that is discovered during a screen must be treated and covered by EPSDT. And conditions do not have to be new to be treated. So it could have been that in the past you've been noticing something that the kiddo was born with, but again, this is that pre-existing condition. It can still be treated for that. Once a child is seen by their physician or provider and a screen reveals a problem, a diagnosis is made and appropriate treatment can be provided. And by law, states must cover necessary health care, diagnostic services, treatment, and other measures to eliminate and support physical, mental conditions, and illnesses. And that means that you cannot deny services based on whether or not they will cure a condition. So this can, so you might just be treating, but it's not curative. If a treatment maintains a child's current condition or makes it easier for a child to live with that condition, in general, it must be covered by EPSDT. And so you can actually get quite a bit covered under EPSDT if you could make a good argument for why it's important. And so a lot of it comes down to a relationship with the medical director also in the appeal process. So the 5 pieces of EPSDT are designed to ensure that all eligible children have access to full range of healthcare services, from prevention to identification and diagnosis all the way through treatment. Oftentimes, the programs that we're talking about, PCS is paid out of EPSDT. Environmental modification comes out of EPSDT. So that's like, for example, our kiddo out of EPSDT, we inherited a house that had stairs. lots and lots of stairs, and our child is paralyzed on the left side. And so EPSDT and the environmental mod through our plan paid for us to put bars on all of the stairs because they didn't have them. So next slide, please. Components of the screening process. So total health development history, including a complete assessment of physical and mental health, complete physical exams, immunization, lab tests. This includes lead toxicity in the blood, health education and counseling, eye exams and other vision tests. I believe glasses up until the age of 3, but now with Medicaid, actually, the extension, I think they'll cover glasses even beyond that. It used to be just when it was medically necessary. Yeah. Dental services, including checkups, cleaning, and preventative work. There are some cases I've seen where the kids are going to have like issues with like TMJ or different healthcare issues where they were able to justify braces because it was going to have a significant health impact. And then hearing services, including diagnosis and treatment of hearing aids. So, okay, it's not coming up for me, so I think they must be asking you directly.
Right.
Oh. Okay, where one can find more info about the 750 respite hours for the child with autism. So it hasn't been released yet. They're working on it at the federal level. So the question is about that 750, 720 hours. Our understanding, and maybe the folks from HSD can clarify for us, either by chiming in or typing it, but our understanding is that it's not done, but our state is also finalizing through the Developmental Disabilities Service Division a small amount of funding for families that are not Medicaid eligible for, was it $2,500 a year that could be used for respite, but I think it's more designed for ABA. There's also, and we can talk offline, the state general fund. So if the family has a child with autism that is on the wait list for the developmental disabilities waiver, then they can get respite hours through the state general fund. And so I'd be more than happy to, whoever asked that, work with you one-on-one if you would like. But yeah, I think people are giggling because we have to kind of cobble together a little bit of a life for ourselves. Is that what we're?
Yeah. You have to foresee the future.
Yeah.
And put yourself on the get respite hours through the
Yeah, because they run out, and so you have to wait, and then you get the hours, and then people don't use them, and then they go back to the state, and then the state says, well, why am I even giving you funds when nobody's even using them, and it's a lot of fun. It's all good times. Okay, so again, what services can be provided? Dental, vision, physical healthcare, mental health, but we know that that's really challenging in New Mexico because we have so few providers that even kiddos in crisis are having to wait sometimes 9 months. And Adam's over there playing with his phone. I know, I'm just teasing. Supplies, equipment. So EPSDT is going to pay for the diapers for kiddos that are not potty trained over the age of 4, because that's considered a medical condition at that point. And a care coordinator, our experience with the care coordinator now is we used to have to call the doctor and ask them to write the prescription, and you don't even have to do that anymore. Our care coordinator just goes and takes care of it and contacts the physician's office. It also covers pull-ups, which a lot of people don't know about, and that's great too for families that are, because they do want to encourage kiddos to be learning how to potty train. I wish they covered swim diapers, but I haven't seen that happen yet. I guess if you could make the justification, but kids with special needs are not being allowed into public pools unless they have like rubber pants or swim diapers, and those can be kind of pricey. So, but you know, if somebody wrote the right kind of goal, they might be able to do that. And then adaptive equipment, supplies and equipment. Any questions on this part? Okay. What are the requirements for services? So they must be medically necessary. So again, you have to kind of make that, and a person that's savvy and that has a good care coordinator are able to do this in some cases. And so again, a lot comes down on the medical director to make these choices. Treatments must fit within a Medicaid coverable service. So if it's experimental, so like my kid went to that rehab camp in Columbia last month, or this month, earlier this month, it is not Medicaid coverable because it's experimental. So it's not been an approved service under Medicaid. So they were not able to pay for the camp. Treatments must come from a Medicaid provider. So if the person is not a Medicaid provider, then they cannot pay them because they're not contracted. However, if Medicaid is secondary and it's a non-Medicaid provider, Medicaid does pick up what's left over. Next slide, please. Do you have a question?
A clarification that to clarify that the diapers and pull-ups are based on medical necessity as a matter of course.
Exactly, yeah. Diapers and pull-ups, medical necessity. What is not covered? So respite care is not covered under EPSDT, but the personal care services. The habilitation that we talked about from the Affordable Care Act is not covered under EPSDT. That would be under what the MCOs have. Targeted case management, and case management is often for a condition or a disease process. So diabetes, hepatitis might have a case manager, cancer, and those would be those specific. Children's medical services can do case management for people that don't qualify for Medicaid with certain conditions. And it cannot work for treatment for another family member. We see this most often if it's in family counseling. So EPSDT can't pay for family counseling. It would pay for counseling for the kiddo. And some providers would work it out that it's for the kiddo and the parents are in to consult. But if it's billed as a family, if a treatment or a therapy or something is billed as anything other than specifically for that child, it can't be covered. Okay. Next slide. So for grievance and appeals, now this is a fairly new deal. They really want you to work with a managed care organization. They really want you to try to do the appeal process, and that's why a good relationship with a care coordinator is really important because they do a lot. They're able to see where things are getting stuck in the process and can help you make the cases. There is a fair hearing process through the state, so that's the next step. And that's something that we really wanted to know about because there are going to be families that are not going to trust their insurance company no matter what we say, and they're not going to want to go through the appeals process. And so they can go to the through the fair hearing process with the state of New Mexico. We have that information available if you want it. You can also go to Disability Rights New Mexico, which is our protection and advocacy organization. Every state has a PNA, and Disability Rights New Mexico is ours. And also the New Mexico Center on Law and Poverty is working. They have a healthcare division that's working specifically on Medicaid grievances. So, so they're keeping track of that. So, next slide, please. This is a little bit redundant, but just so people understand. So when they get Medicaid, they're going to get this blue card. But when they choose their MCO, they're also going to get an MCO card. And that can get kind of confusing for people because they'll bring both of them. The card from their MCO is going to be actually more important because it's how that's the thing that the doctors are going to want to see. That's the thing that they're going to call the numbers on to get assistance from. And again, it's based on citizenship, income, and other factors. Age is a large one. It costs $5 to replace your blue card. That's good to know. Yeah. But when is the last time you've had to use your blue card? I don't know that I ever. You have to show me your blue card when you file for SSI.
The numbers. My card.
Yeah.
The overall.
The Medicaid number. It gave the MCO number. Yeah. That's interesting because I know we have a blue card like in a box in my basement, but I just.
I have to create it. I have to show my blue card here, and then
okay. That's good to know. That's good to know. Okay. Okay. So Melissa and I need to figure out where our blue cards are. Yeah, or be all $5. Yeah, exactly. So Great. Okay, next slide. And this is just reiterating, this is just for visual learners. Centennial Care is Medicaid. Medicaid is Centennial Care. And we'll still have people say salute, and we just gently correct them because it's not salute anymore. Physical health, behavioral health. Yes, this is really redundant. Awesome. One more? Okay. And if you have any questions, you can look for more information on centennialcare.net. You can call the New Mexico Medicaid call center. You can give us a call. The next slide are the groups that helped us put this together, which was New Mexico Center for Law and Poverty, Blue Cross Blue Shield, Health Insurance Marketplace, and the Human Services Division Department. Do we have any questions about what we covered in here? We understand? Are we ready to get the most out of our Centennial Care in our EPSDT? How about on the phone? Do you guys have any? We'll go ahead and unmute the lines if anybody wants to ask any questions or clarify, contribute. Go ahead.
Yeah.
Oh, someone's on the phone, I think.
No. And the thing is, though, like, even not just the rested hours you would have control over, but even like.
Okay, so we had to mute everybody because somebody was talking on the phone. Does anybody want to chime in? Questions, concerns? Erica? Or Truletta? Okay, we have a question from in here. Go ahead.
When you first came, was not just for yourself, and then
it depends on what score you get. So the question was, when you do a health risk assessment, are you supposed to get it yearly? If you get a 1, then you'll get a call yearly. If you get a 2 or a 3, then you get sent to care coordination, and they'll do a comprehensive needs assessment. However, if anything changes at any point, you are welcome to call in and ask for a comprehensive needs assessment. I think it's Yvonne, right, that always tells us about you can also make an urgent request for care coordination. So let's say that all of a sudden your kid or yourself is in crisis, you're feeling overwhelmed, you're not understanding, you can call and make an urgent request for care coordination or an urgent request specifically for behavioral health care coordination, because they have 2 types. And whatever the primary concern is the primary contact that they're doing. There's someone off of mute. Did you want to ask a question or make a comment?
This is Henry, Lisa.
Hi, Henry.
I'm a care coordinator for Presbyterian Centennial Care. A couple of things. One, you're right. The HA is only done yearly for level 1. Once the HA is done and you're determined and it's determined that you're level 2 or level 3 care coordination, then the CNA, the comprehensive needs assessment, is done yearly. Mm-hmm. And I just want to let everybody hearing, everybody listening, we're required as care coordinators based on the Centennial Care contract to contact our members quarterly. But really, that's a minimum. And we are to contact our members as needed to support them in their goals, to address their health needs as they come up. And I really agree with you that a care coordinator is a service agent of the insurance and is an advocate for our members. And if individuals that have care coordinators do not believe that the care coordinator is advocating for them appropriately, then they should request a change in care coordination. We've been directed by HSD that individuals can change once, maybe twice care coordinators, but typically what we're trying to do is find a way to negotiate and kind of get agreement on what the member needs with the care coordinator that knows their needs best, rather than putting a new care coordinator in to have to reassess and reorient to the member's needs.
Awesome. Thank you so much for that input.
Don't fire them.
There's a question from in here.
So when the care coordinators call for their quarterly assessment, expecting us to be at their schedule. Notice.
reaction?
Hang on, we've got people talking. There we go. Okay. So the question was if the care coordinator is contacting you, and I've seen that where they'll just call you at the last second because they realize that they're going to get penalized and they need to call you. I mean, that's not your responsibility.
They have to come out and see the whole entire family quarterly.
They do. I think
quarterly?
I don't. It sounded like Henry said they do
the level of
care.
Qualified for. And so you can work with your care coordinator to say, look, I work from this time to this time. These are better days for me. These are better times for me. And a lot of the care coordinators will work with when you're scheduled. I had 3 contact me last year and I could work that schedule. They're like, well, if you're not home, work. Then,
no, because ours come at 5:30 at night. Ours come after hours. Yeah, because we work too. It might be, yeah. It might just be people, and you know, and we've seen that. I mean, it's something that we talk to the insurance companies about, where it's this kind of like, you know, your lack of planning doesn't really inspire me to, you know, kind of drop what I'm doing and stuff. And so then they learn with me that they need to call me with after hours time. You know, so just working with them, just saying, I just can't do it, you know, and they really can't threaten because it's not, you know, I've heard that some families say that then they were threatened that then their Medicaid will be turned off, and that isn't the case. I mean, it's one thing if you're really just not working with them, and that's where documentation might be really beneficial for you, to show when they've called you and what they've offered you, and just kind of being clear in that case. But no, they have after hours.
Do you think maybe one of the care coordinators that's on the call can kind of explain maybe how that works with the care coordinators and what their suggestion would be? Like my son and I are on the highest level.
3.
And then my other 2 on the middle and one bottom.
Okay. So I don't know, Henry, did you hear what we're asking is just he has 4 people that are on Medicaid. 2 are 3s, one's a 2, and one's a 1. And they all have different care coordinators, or you have one care coordinator? You have 3 care coordinators, and they're all calling and trying to coordinate, but none of them are offering after-hours appointments.
So I have been instructed by my supervisor at Presbyterian to accommodate individuals that need to be seen after hours. Now, is it something I go there, you know, joyfully? No, but I've been told by my supervisors that I can adjust my day, which is 8 to 5, to accommodate evening appointments with members. And then I can adjust my day with comp time during the day so that it's not an overextension for me either. So I would say about 10% of my members ask me to accommodate their work schedule in some way with after hours meetings or contact time, phone time. So I have 4 required touch points a year. 2 of them are over the phone and 2 of them are in person. Especially with children, it's possible to call the members' parents at work and have a conversation for half an hour if there's no specific extensive needs and they have a confidential place to talk to me. I certainly appreciate them accommodating my time, but it really is around the members' needs and the members' parents' needs. And I try to accommodate that with all my members on my caseload.
So, Lisa, this is Yvonne.
Hi, Yvonne.
So Henry's correct. We feel that care coordination with Presbyterian, I can't speak for the other MPOs, but with Presbyterian, it's member-centered. So most of our kiddos go to school during the school year, and so we try to work around the parent schedule and the member schedule because the member has to be in the home when we complete our assessment. So it just depends on when that member is going to be available along with the parents, and we have asked our care coordinators not only to visit after hours, which some of our visits are done like at 7 o'clock, 8 o'clock at night, and a lot of our care coordinators do have to travel in order to meet the members' needs. and we do allow the care coordinator to fix their time the next day or during that week in order to accommodate our members. And if they're a level 2 member, level 2 care coordination, they are contacted quarterly and face-to-face, as Henry stated, it's 2 telephone visits and 2 face-to-face visits. It's a level 3 member, which has more, they have more complex needs. They are contacted monthly, and we complete a face-to-face visit on a quarterly basis, and we do a semi-annual CNA. If they're level 1, it just depends. If they're level 1, then we will contact them on an annual basis. That means that they do not require care coordination.
Thanks, Yvonne. And are you on all different insurance plans? Is that?
No, it's all the same insurance.
Okay. So you could also request that you have all the same care coordinator. They can do that because, like, my kiddos all had the same care coordinator. That might benefit you guys to have them manage all of you guys. I mean, sometimes it's tricky because they'll have a child and an adult, but at least if you got the kids under one care coordinator and then yourself under another, they might be able to find somebody that's experienced in both, in adult and pediatric, to do all of you guys. That would probably be a good solution, I would imagine. That's a lot of really cool manage, yeah. And
it's best to have one care coordinator work with the family.
Right.
Because when you have 3 or 4 care coordinators going into the same home, it makes it very difficult to communicate all the needs of the members. So it's best to have one care coordinator assigned to all the family units.
And then, Yvonne, have you guys, they were talking about streamlining the HRAs so that they would all be the same. Have you heard any progress on that one?
They're working on it at this point in time. They are supposed to be putting that into place. I have not heard anything as of today, but I know that they informed us on Monday during our meeting that they're working on that and getting that ready to roll out. So it should be streamlined, and I think everybody should be following the same HA.
Yeah, because like for each NCO had their own health risk assessment or HA, and then but they'll also have their own CNAs, right?
As far as I know, yes.
Okay. Okay. So that could look very different, the questions that they ask or things like that. And then, Erica, are you still on the call?
Yes, ma'am, I am.
Hi, can you tell us about, since we have like providers shifting around and stuff, can you tell us about how individuals can switch companies in the event that they want to stay with UNM and United isn't participating, or anything comes up?
Well, they need to make a request to do it. So what they'd have to do is they'd have to contact our office to make a request to see if it gets approved. And what the reason is, if there's necessity, and what the reason is, but they'd have to contact, and they go through a process of applying, making a formal letter of request to be switched with a little reason.
Okay, is that the 1-888-997-2583?
Mm-hmm.
Okay, awesome. So if we have families, because there's just so much kind of uncertainty right now moving around that people are moving all over the place, so letting them know that.
Yes, and they do have that option to make a request.
Okay.
It's just a request, though. There has to be particular needs and particular criteria met before we just make an automatic switch until they're eligible to.
Great. Thank you so much.
Thank you.
Okay. Any other questions about Centennial Care, EPSDT, any of that stuff? All right. Well, awesome. Thank you guys for joining. Oh. Was somebody? Nope. This meeting? Okay. Thank you all for joining. We're going to go ahead and shut it down and log out, but I appreciate your guys' conversation and participation. Erica, did you have something to say real quick? Nope. Nope. Okay. Thank you guys. Have a good day. Thanks, guys.